next session is on establishing child psychiatry services, for which I invite onto the stage chairpersons Dr. Ram Subba Reddy sir, Professor of Psychiatry in Nilofer Hospital. Welcome, sir. Dr. LVR Ushara, Professor of Psychiatry at Institute of Mental Health.
Good morning, everyone, and thank you for giving the opportunity to Dr. Ashok Kalim Chandani sir for this session. Now I invite our today's speaker, Dr. Gauri Devi Garu, to come over to the dash. The child psychiatry clinic. Unlike adult psychiatry centers, this is establishing child psychiatry clinic is completely different because of the overlapping of symptoms in child psychiatry and because of the heterogeneity of the presentations in the child psychiatric disorders. Multidisciplinary approach is necessary to address the problem. There should be a speech therapist and a physiotherapist. And all these
excuse me, you put the
staff
wrong
are
one.
required by Government of India, and now we are able to diagnose as early as possible, between 0 to 3 years.
Established.
And not only the child psychiatric conditions, we should assess other impairments like visual impairments and hearing impairments, and sometimes sensory integration is also needed. I don't know how far it is possible to start all these things in outside child psychiatric clinics. Today we have an excellent speaker, Dr. Gauri Devi Madam, with vast knowledge in child psychiatry and child and adolescent psychiatry. Madam will enlighten us regarding the starting the child psychiatry clinic.
It gives me great pleasure to introduce our speaker, my guru, Dr. Gauri Devi, who is currently Director of Child and Adolescent Psychiatry, Senior Consultant at Asha Hospital. She runs Access Psychology and separate Child and Adolescent Clinic in Somajigoda, affiliated to Asha Hospitals. She has published and presented more than 40 papers. Her special interest is, of course, child psychiatry and counseling. I request Dr. Gauri Devi to give her presentation.
Thank you, chairpersons. I think I'm audible. I'm audible? Respected dignitaries and the speakers and the chairpersons, the faculty and the students, I'm very glad to be here and talking about a topic in child psychiatry which is of my favorite, of my interest and my favorite subject and my passion. And here I would be talking to you about the child psychiatric clinics. The advantage here is I'm not going to talk about inpatient services and admissions and what is required for child psychiatric problems. It's only clinic, so how to establish it. So as you know, most often the child guidance clinics are run by the pediatricians. As the DME was pointing out, it's a nominal departments in most of the medical colleges and they're always associated with the pediatric departments. So they'll have a clinic and a psychiatrist. So hardly there used to be psychologists in the past. Slowly the psychiatrists are being added, and like when you look at, because I worked as a PG and also senior resident in the Central Institute Child Psychiatry Department, that's in NIMHANS, and subsequently I worked as faculty in state-run child psychiatry department in Nilofer, and also had seen the private child psychiatric clinics like Nair Hospital, and I have idea about PGI and Vellore. What I found is either infrastructure is deficient, like most of the state government hospitals, they don't pay attention to the psychiatric department, maybe 3-4 rooms are given and you need to manage. And the Central Institute, like where I did my post-graduation, and it started with 3 or 4 rooms when I was senior resident, worked there for 1 year. Now I know there's a wonderful building, 2 buildings, one for adolescent and the other one is for general child psychiatric cases. I go as examiner and I have seen beautiful infrastructure, but the resource persons or the faculty, not much change in number, in terms of number, it's increased. The various number of psychiatrists are more, the psychologists are more, the social workers are more, but they don't have occupation therapy and speech therapy departments, and they don't pay much attention to the neurodevelopmental disorders. It's mostly child psychiatric disorders and adolescents. So why I'm saying this is that there is no norm for formulating the child psychiatric units. And when you Google, and it's interesting to know that most of the child guidance clinics are run by the clinical psychologists or occupation therapists or special educators. So that means there is no commonality in child guidance clinics. So with this, and having had experience of like being a student from the institute and running in, working in state government hospital and seeing few probably, one thing I found is Nair Hospital, like I visited when government of Telangana sent me, I found that its infrastructure is not very good, but functionally it's good. They have all the facilities. Having kept in this mind, when Dr. Chandrasekhar approached me, wanting to start a separate clinic, and I think one thing we need to know is establishing a clinic or a specialty, it involves a lot of money, manpower, and motivation. I had motivation, but the only thing is I was worried about finances, and Chandrasekhar was kind enough, and he encouraged me, in fact, to start the thing. He's a motivator. So with that, we started this Access Psychology, wherein we had that child guidance clinic, and I said I'm going to have full-fledged department with all the people who cater to neurodevelopmental disorders and school-going children as well as adolescents. And any clinic or anything, when you want to start, you need to know whom are we serving and what are the problems, whether it's child or anything. I mean, what are the problems we are going to handle? What is the extent of the problem? And what are the resources available? What should be available? And what are the services we need to do? So this way, I think when you have a plan, you can organize the services. When you look at it, first I just would like to give an introduction, like the importance of having child guidance clinics or child psychiatric clinics. We know that 2.5 billion children, they constitute the world population. Out of that, we know 444 million children are in our country, which constitute the largest child and adolescent population. More than 1/3 of the country's population is below 18 years, which is a big chunk of the population. When you look at the importance given to the children, when you look at the national child health schemes like National Rural Health Mission or National Urban Health Mission, you know, the emphasis on the physical health of children, and very minimal focus is given to mental health of the children under school health program. And next, when you look at the national mental health programs, I mean, I was also running that when I was superintendent mental hospital. There is one or two classes on child psychiatry which is taught to the primary health doctors, the teachers, and the ANMs. That means very minimal focus is given to that. In the 11th program, they mentioned about child school and college health programs, mental health programs. You can imagine and it is not really taken off. So that is the state of affairs for children. And as you know, child is a very important phase in the life of a human being. It starts with infancy and it goes to the adulthood. And development of the child, definitely it's a process involving interaction of inheritance and environment. And early years of child life are very crucial for cognitive, social, and emotional development if you want to have a fairly good personality development as an adult. Psychological development is a very complex and compared to physical development where you can give nutritious food and care. Just want to give importance of how difficult the psychology of the child. So in the child, we see the behavior. What you see behavior is like no iceberg of the, it's top of the iceberg. What we don't see, what is required to see is what is under the surface. like the child's developmental level, the need for basic needs, the sensory needs, the emotions, and the social skills, whatnot. So the whole thing, to make a person a strong adult, so much of work need to go into the psychology of the child to become a good adult. And let us see what is child mental health. So because we are going to talk about services for the child mental health. We know foundation for very good sound mental health is built early in life with the experiences shaping the architecture and developing brain. Here I would like to emphasize for the PG students, in early developmental disorders, we use mostly the stimulatory methods, early interventions. Why are we doing it? It is, that number of cells are formed, but there need to be connections between the cells, which can be done with the stimulation of various sensory modalities. That way, the architecture of the brain, if it has to be, that means early intervention is very, very essential. Later, as the child grows, the experience the child has with, parents, the caregivers, the relatives, teachers, and peer group, they will shape the social, emotional, and cognitive development. And so effective management of any child issues involves early identification of the problem, need not be a disorder, and identify the causes. Is it the cause at home or cause at, with a peer group or the studies? And we need to find out the appropriate source in the formative years itself so that we can handle it effectively. So what are the extent of child mental health services? As I said, like when you want to plan, you need to know what is the extent of the problems which the children have. Most of the studies all over the world, they agree the number or maybe little different with the reference to percentages or few numbers. But all over the world, they say that 10% of the children and young people between 5 to 16 years, they have clinically diagnosable conditions using ICD and DSM. That means a fairly good number. 20% of the adolescents may experience one mental health problem at least in any given year. 50% of the mental health problems are established by 14 years. Like if a child has to develop a depression, by 14 years you can see the signs and symptoms of depression. It could be subsyndromal or syndromal. And by 75%, by 24 years, you can identify the child developing slowly the depression and settling down. 70% of the children and adolescents who experience mental health problems do not get appropriate intervention at early age. That's very important. Getting treatment at early age and being identified. Youth suicides between 10 to 19 years are the second leading cause of death. Yesterday in the Times of India, I was going through and there's a very interesting article which is given, and it says that the child and young adulthood suicides are 3 times more than the farmers' deaths in Telangana. So that's a fairly big number, and it amounts to 26.8% of the deaths. That means you can imagine the deaths in young people is becoming, as DME pointed out and rest of the people also pointed out, it's a huge number. We are going to lose young and energetic and the future citizens of this country. And another important interesting thing is the rise in hospitalizations. Like at least some 5-6 years back, I didn't have many people coming for admission. Now, it's really heartening to see the parents rushing and bringing their children for suicidal attempt or severe aggressive behavior. So, and all over the world, they found that there is drastic increase in the admissions starting from the age of 5 years to 18 years, which is a huge number. They pointed out that 50 to 80% of the children are getting admitted for some problem or other, behavior problem or substance use disorder, behavioral addictions, and non-suicidal self-injury. And in fact, in our hospital itself, I have admitted quite a few children and adolescents with suicidal attempt and non-suicidal self-injury and severe aggression. violent behavior and attacking parents and injuring them. And with substance abuse, like two doctors as a couple, they brought the son who is a very brilliant boy, assaulted mother so bad that she, he punched her nose and she had injury over the face. It's, the boy had bipolar disorder, also has substance abuse, and he, in intoxication, he attacked them. So that after the treatment, like we admitted it, detoxification and then afterwards de-addiction center, they pushed him to America straight from de-addiction ward. So they were damn scared. You can imagine that like 19 to 20-year-old youngsters becoming so violent and getting admitted. And coming to the mental health services, what is that? We are talking about the extent of the problem. Then what is that we need to do for either outpatient or inpatients, or prevent inpatient admissions? So it should be a comprehensive program, and there should be a systematic approach. It's not that you see a child and put him on medication and just advise the parents to look after. That's not enough. So the goal should be like mental health promotion. That means you need to encourage people to identify the problem and see that the stress factor for the children are reduced. It's not that they need to be pampered and not, not be put under pressure. They need to learn the adaptive functions. The second is illness prevention. When we know that there is vulnerability, we need to think about preventing little early. Say, for example, we have children with autism risk who come to us. Around 2 years of age, parents who are very sensitive, saying that there seem to be some problem with our child. Sorry. In such cases, when you observe, we need to immediately take them for early intervention. I've seen number of children who come with very mild symptoms, autism risk. We do with the MChat. And we start them on early intervention. It's surprising to see that the child grows well, almost near normal, and gets into the normal school. So that means illness prevention is also very important, and early detection and management. I will not be going into the details of the disorders and things like that, because it's establishment of the services. Next, it should be driven by the needs and preferences of the child and family. You can't have, one size fit all. So it should not be. And early identification and individualized care for the child as well as the family. Like, okay, we have the norms saying that when you see the child with the behavioral problems, okay, you need to examine and do the psychological testing and do behavior modification. So even behavior modification, you need to look at the child's problem, priorities, and the family circumstances, and you need to look into the individualized care approach need to be done. And it should be integrated. When you see a case and refer to somebody else, it's not that it's the end of the, your job is over. No, you need to have a liaison with the person to whom you refer and discuss. And it should be evidence-based. It can't be just, I feel, it looks like, no. It should be, definitely evidence-based, whether it's medical, psychological, or other interventions. And finally, what you are aiming at is the social and emotional development of the child, because if he has to handle the, the problems in the future, I think these two are important. And there should be coordination, as the chairperson was pointing out. It's a multidisciplinary. So you need to have coordination between the different disciplines and the care providers, and also the services which we give, and whatever mental health programs which we do, and education of healthcare providers and the staff, and referral and liaison with other professionals and school personnel. So what are the problems with the delivery of care? Like we say, like child psychiatry should be established. We need to have good care of the children. Yes, the idea is good, but we know that mental health problems are not recognized early. That's one, because either pediatricians or the other physicians, they don't have a good knowledge about it. Even our psychiatrists, we hardly have much training unless you have more interest and learn about it. There's not much training. Services being unavailable. And hardly we, as I was pointing out, the comprehensive services are not available in child psychiatry in any of the states. Mostly urban areas, you have certain centers, maybe attached to medical colleges or the institutes, and more than that we don't have. And even if they are available, inadequate utilization. And I have seen in Nilofer, very few referrals come from the pediatrician. Most of it is from outside, from the schools. Now they do refer, but only the cases which they feel that we don't want to handle. It's not the patients want. It's not that they don't want to handle. Few cases they say, like, what is that child psychiatrist, do it. We can put them on medication. Enuresis, encoparesis, what is that they are going to do? We'll put them on medication. We are taught imipramine, and so we put. So this is what you call all over the world. Interesting to know that most of the pediatricians, they don't refer to the psychiatrist, child psychiatrist, and they either manage or they tell the parent that it will pass off. It's very interesting to note all over the world. Lack of awareness and access to available services. And it's interesting to note that 49% of the children who need, they don't get help. And there was one study, they mentioned that 2 million children were diagnosed with depression, but only 39% of the serious, turbulent, and severe depression cases had treatment. You can imagine depression, which is a common condition, should be treated so early. It's not being treated, only 39% get the treatment. And as you know, socio-economic background people all over the world, for all services, they don't get. So the barriers, as we were talking, I don't go into details. The cost-effective infrastructure is not there. And the lack of cross-system collaboration and integration is not there. Shortage of qualified persons. We have shortage of psychiatrists. Then can you think of having child psychiatrists? And lack of training, as I was pointing out, as PGs or residents in the psychiatry, very minimal training will be there in child psychiatry, and poor interagency communication and issuance issues. So who are the stakeholders? Then we need to identify who can help these children with mental health problems. One is mental health team. I won't go into details. Anyhow, I'm going to talk about it. The psychiatrists, the psychologists, social workers, and others. General health care systems, like in the rural areas, the PHC medical officers, and the districts, the physicians and the pediatricians, and medical colleges, pediatricians and other physicians, and educational system, the teachers and the school counselors, and child welfare system, where the children who are disadvantaged socioeconomically, and they're kept in the hostels where they have emotional problems, and also they have problems with education. And the juvenile justice system, now it's become very active because of the POCSO, and a lot of child abuse is happening. And then family groups and caregivers. We have groups for autistic children. The families, they form a group, and similarly with the ADHD and SLD. And at least I felt very happy that the parents of SLD children, they approached the government and they pushed them to give certificates in Andhra Pradesh, the previous Andhra Pradesh, and now Telangana. That was the reason I went to Nair Hospital, where they were certifying and doing it. We are the last state to follow all these norms. That's unfortunate. And I'll not go into details. Your ICD-11 and DSM gives you all psychiatric disorders. The commonest we find in our clinics is the neurodevelopmental disorders, like intellectual disability disorders, autism spectrum disorders, and specific learning disorders, ADHD, which are the major chunk of population who are coming to us. And disruptive disorders in the school age, we know oppositional defiant disorders and conduct disorders. And because this, especially post-COVID, they have gone up, because children were parents, and parents were insensitive to them, and they were, lack of discipline or too much of discipline, and the problems keep increasing. And emotional disorders of infancy, or mood disorders and anxiety disorders which exist in adults also occur in children. Another big population is adolescent adjustment issues, like deliberate self-harm and non-suicidal self-injury, And now important thing is relationship issues, either with the parents or with the teachers, with the peer group. Very important thing is a kind of heterosexual relationships starting from the age of 10 years. The schools, pushing the child out, saying that, he is trying to send a love letter to the girl in the class or things like that. I mean, the relationship, exposure to media and then the serials which they see and the YouTube, we all producing youngsters going for the love affairs, having a girlfriend or a boyfriend has become the norm of today's youth. And substance use disorders and behavioral addictions, which I don't, already previously the speaker has spoken to. So let us come to the child psychiatric clinics. Child guidance or child psychiatric clinics or the specialized clinics. That's why we are here for the theme. And we have to deal with normal as well as abnormal intellectual abilities. It could be borderline average and also extreme, severe and moderate cases. And also specific learning disabilities and, learning difficulties and other motor disturbances. Management of wide behavioral and psychological and emotional problems which cause maladjustment, and providing medical, psychological, social amenities for management of maladjustments in children. I'm not talking about disorders because many times we come across children and the families coming with maladjustment, not really disorders. And we need to have collaboration and referrals and, with the linkages, family and community, which I already alluded to. And let us see the functions, like you need to think about not only the what services we do, how it functions. It should function as a multidisciplinary, multimodal team approach. And psychiatric services should be evaluation, diagnosis and referral to the concerned departments where there are deficiencies in the child. And after the examination and the reports, plan the management and discuss with the family and take the consent and their approval for the management. And then psychological services, again assessment of various cognitive or emotional aspects, and therapies for children and parents. And next is speech evaluation and therapy, occupation therapy and evaluation, and educational assistance in terms of assessment of the disabilities and special education for children with mental retardation, and also remedial training for SLDs. And working with the families and schools is very, very important. We don't have, unfortunately, social worker because the trained people are not there. Maybe we are planning to have social workers also. Mostly what I'm doing is by way of sending them letters through the parents about the child's problem and what need to be done, or the child has bullying, so we need to educate. And also we train the teachers about the various common psychiatric problems. A child who has got school refusal, liaison with the school teachers and the principals we are doing. Working with law enforcing, juvenile services and social welfare and other medical professionals. We recently started having a kind of liaison with the juvenile welfare services where we started giving them, common psychiatric problems and how they need to, the caretakers need to take care of the children with various emotional problems and sexual abuse and other things. And this is what is important, infrastructure. Most often as we are given a small corner in the pediatric department or pediatric hospital, and even in general hospital where a small portion is given to psychiatric department. So in child psychiatry it should be friendly hospital atmosphere, and it should be away from adult psychiatric. Previously when I was practicing both child and adult psychiatry in Asha hospital, and it's really cumbersome in the sense children take longer time. Adults, they feel very bad. And children are exposed to adults and they get frightened. So that's how, we thought about the separate thing. There should be a waiting hall with some educational material for the parents and activity material for children. Because children will be restless. You make them wait and then make them do the psychological testing it takes. So if you have activity materials, you can establish a rapport and the child will be more comfortable. And the parents also, if you give educational material, they go through it. And consultation rooms especially designed for the children with small tables and benches. Maybe adolescence is almost like an adult. And we need to have a separate room for psychological assessment and therapy, speech therapy room, and it should be soundproof with a lot of padding so that children will not injure themselves. Similarly, occupation therapy with so many gadgets. To make them, it should be huge, and the children can run around and play with the toys, and also have exercises with quite a few gadgets which we have. And the sensory room for children who have got problems with the sensory integration, especially autism spectrum disorders, and isolation room for ADHD children where you cannot really control their overactivity, and also isolate the children who are aggressive for a short period of time and to control their aggression, and special education room with a lot of special education material, and play therapy room. I'll be showing them quickly, so I don't want to go into details. So that is the infrastructure, and the personnel and material I'm going to talk about it. Child and adolescent psychiatrist, which we don't have. We don't have that fortune. But most often it could be a psychiatrist who is trained fairly well in the common child psychiatric conditions and simple methods of management. Then child or clinical psychologist, and a qualified speech therapist, the occupation therapist, special or remedial educator, psychiatric social worker, and a family counselor. Because most often we found that the parents have a lot of issues, interpersonal issues, which is affecting the children. So we need to have a family counselor who deal with the conflicts of the parents along with the child management. And coming to the psychiatrist, quickly, the training in child psychiatry is essential. That's how we have a postdoctoral fellowship in child psychiatry in various places. Like in our institute, we started in 2017 with NTR University. Now it's KNR University, and they gave us permission, and we are running, and there are a few people qualified and practicing outside. And also DM child psychiatry in Nimhans and Chandigarh. So, slowly there is awareness, and people are really pushing for, increasing the number of child psychiatrists. Otherwise, the psychiatrist should have knowledge of normal and abnormal development across the childhood. They should know which are the medical or neurological conditions that can produce behavioral problems, or the comorbid conditions which can change the course of the child psychiatric condition. And it should be examination, that means history taking. I'm not going into details. The evaluation, diagnosis, and the referral to the concerned people, and planning the management and discussion with the parents. This is our center where I have my postgraduate fellowship girl talking to the child and evaluating the child. And next, child psychologist. Again, it is from the institute where my psychologist is examining the child, and she's MPhil in clinical psychology with experience in child management. She's trained from Velo, and assess for child cognition. I'm not going to details, DQ, IQ, and screening for SLDs. And similarly, we get temperament and personality assessment to know the strengths and the deficiencies of the child, so that when we plan the management, it will be easy. And diagnostic psychometry, and knowing the interpersonal or intrapsychic conflicts, and screening for developmental thing or assessment of the neurodevelopmental disorders and other conditions. Therapy for children, our psychologists, and including my residents, they take up the children for individual therapy, play therapy, and ABA and behavior modification. And I formulated ASHA, early intervention therapy for children with autism, taking up all the studies all over the world where they found that intervention at family with the family members is effective. And we formulated the techniques, and we made a module. It's extremely good, and it's a comprehensive, and now I call it ABCDE, and development based, and comprehensive, and behavior oriented, and it's a comprehensive one. ASHA, I put ASHA in the beginning, A. So that therapy we use, and we found wonderful results. And this is voice output, AAC, augmentative alternative communication, which they use, and picture exchange communication. So these are all the material which the speech therapy uses. and occupation therapy. This is again from our department or our center, where the occupation therapist is helping the child with the sensory issues, making the child walk about on different textures. And so a qualified occupation therapist experience with children, and occupation therapy assessment will be done by her with reference to gross motor, fine motor, coordination issues and sensory issues. They take them therapy for gross motor and fine motor, and also sensory integration therapy, which can be done very easily, and to improve sitting tolerance for ADHD children. So make them sit on the balance and do it, and adaptive functioning training, they do it along with the parents. So OT room, you can see like she's sitting with the child and making the child to develop eye contact, and looking at the object and joint attention. And there are material for coordination, climbing up and jumping, and so these are the material. And they're all materials for gross motor, sensory brushes, and chewables and oromotor with soft to hard biting material, and fine motor, how to make the child hold the pencil. And the last one is for children to develop power, upper limbs and lower limbs, when they have coordination problems. And ball pits and sand pits, these are all the things which are being used, isolation room and sensory. And special education is also very important, because we have liaison with the schools, where they refer children with intellectual disability, where they have problems in understanding, or SLD children, where they have problems in reading and writing. And they need special, they come for certification, also remedial measures. So we have a qualified special educator who is coming, and she takes up early intervention for intellectual disability disorders, and life skill training in the personal and social skills, and special education for children with intellectual disability, training the parents, and also remedial training and pre-vocational guidance. There are children who come little late, say they are around 12 years, 13 years, they haven't developed anything. Such children, we do the pre-vocational assessment and see their skills as well as interests, and put them to pre-vocational guidance, and then send them for vocational guidance. And parental guidance, as you know, in child psychiatry, that's the important thing. If whatever you do, if the child wants to be improved, I think parents should pursue with whatever we do. Special education materials, I don't want to go into details. You can see what are the things they do, like numbers and letters. And so coming to the last slide, this is the extension program. I will not be elaborating on that. All of you are aware in as PGs, we are all told about it. School-based mental health services, I already alluded to, children who come with a school refusal or having problems with the peer group because being bullied or other emotional problems, or study problems with various subjects. And integration, the second one is integration into primary health care services, like National Mental Health Program, which we already started, and then maybe we are continuing. And awareness and training programs for other specialties like pediatricians and sometimes neurologists. And I feel these days obstetricians need be told, because the children are coming with, because of the hypoxia and, natal complications. A lot of children developing, neurodevelopmental disorders. So maybe we need to have training for them, and family-centered, team-based services. The few families with the autistic children or the ADHD children, they do come. We haven't started, but we are planning to have family-centered, team-based services. And educating and law enforcing agencies, I don't think I need to talk about it. Working with juvenile justice, which we already started, especially for children with criminal behavior or conflict with the law, and POCSO. Of late, we are getting cases where they are asking us about the therapies, and social welfare programs for children and women, where the children are kept, orphans or underprivileged children are kept in the hostels. They do have emotional problems. Like we do come across hysterical conversion, dissociation, and such children are being brought to us. So with this, I would conclude my talk about establishment of child mental health care services with a quote, children are not problems, they have problems. Focus on helping the children. She said your child, not fixing your child. So this is the quote by NOST, child development researcher. Thank you so much for your patient hearing.
Thank you, madam, for finishing the topic in time. Now the topic is open for discussion. Any questions?
Hello, ma'am. I'm Dr. Rishi, ma'am. So that was nice lecture. I have, because I work in a government sector, always worried about the centers which are popping up every day, outside centers which are not managed by a psychiatrist. Most of them are clinical psychologists or not even clinical psychologists. And I see every 2 to 3 kilometers there is one center. So I need you to comment on how about bringing them into a state mental health authority like de-addiction centers so that it can be controlled, because the charges are pretty high for the family members. They charge pretty high, and the centers what they are giving is also not qualified therapists. What I have seen, very few are very qualified therapists. One therapist will be dealing with all the centers. Any comment on that about controlling state mental health
The
authority?
problem here is who can start the early intervention centers.
It depends upon the will of the government and the will of our medical faculty. See, what is happening is, of course, we need other services, and we need to be very clear that the children should be seen by the psychiatrist and they decide it. And it's always psychiatrist being the team leader. But unfortunately, what is happening is that because there are no regulatory mechanisms, and we are not insisting on the medical management as well as the psychiatrist being the team leader, this is what is happening. It's not only here, I think it's happening all over the world. Everybody fighting for their rights. And it's also interesting to note that I was reading about American Child Psychiatric Services. There again they mentioned the child mental health services are in array basically because it all depends on who is starting the centers. If psychologist is starting the center, his or her focus will be on only psychological interventions. And early interventions, they say ABA, and then somebody else will say speech therapy. They contradict. This is the case. I think we need to take it up maybe at the IPS level, and also maybe at the state level. Maybe we need to educate which is going to be a difficult task. I don't think it's such an easy thing, and it should be done by what you call the government, the psychiatrists, rather than the private. Like even if we talk about it, they will not be. Or we need to take it up by IACAM, Indian Association of Child and Adolescent Mental Health, and maybe some other suggestions. It's a difficult task because many times the children are seen by the psychologists and occupational therapists, and they say there's no need to go to psychiatrist. They always clearly they mention, and there is delay in the management, and they come to us. And even hyperactivity, when we put them on medication, they stop, saying that you can develop tolerance by our occupation therapy and other things. That's the reason we have this center where we are providing all the things. In spite of the cost which is involved, we wanted to make a little model center. That's the reason we have taken up the training of child psychiatrists, and Asha wants to be the center so that we can show people that we can have all the modalities working together and doing it. So, yeah.
For CGS employees, where
Pardon me?
there were guidelines released for them, they get monetary benefits from the government itself. So they have designed a protocol for doing therapies. So 3 days of OT and 2 days of speech therapy.
Yeah.
If required, then it is only behavior therapy, and it should be a qualified therapist. They have released the guidelines.
Yeah.
So nobody is practicing that.
Practicing
so how
that,
to adapt it and how to go about it in the centers, it's again the policy.
Yeah. Yeah, that's what I'm saying. Policy matters will not go into, but at least what I just want to say is that center with that, don't worry about it. I think all of you, after you finish your psychiatry, if anybody is interested, have a little bit of training for long period, and you can start with a psychologist, at least visiting psychologist or anything. I can understand, I mean, like Dr. Ram Subba Reddy telling me, the so-called Nilofer Hospital having a child psychiatry department only running with, psychiatrists and the visiting psychologist. It's a bad state of affairs. I think government, I mean, like, no, what you say, the laziness or the lack of interest or inefficiency or whatever it is. They've been trying, but they're not able to. If such is the case, I would advise youngsters, you can start the clinic with the visiting psychologist, and you will be a psychiatric social worker and liaising with the schools and with the families. That's the simplest thing which you can do.
I think there is no clarity in Mental Health Care Act regarding the psychiatric clinics.
Yeah.
How to start the psychiatric clinics.
Certificate. Yeah, see, basically, they come under social welfare department. See, there is always a kind of confusion between, health department as well as social welfare department. Most of the orphans and other children, they come under social welfare department. So I think I'm not very sure about it, how they function. Maybe they need to get permission from the social welfare department rather than, because welfare of the children is more important than the mental health there. Because they do refer children when they have problem. At least as I remember when I was working in the government service, it is the social welfare department, whether it's mental retardation or anything, they were handling it and they would separately contact us.
Yeah, but in the Mental Health Care Act, it is mentioned that even 2 or 3 mentally ill, wherever they are kept, they should have a separate
Yeah.
registration. So, is it necessary or not?
That I think you need to. Maybe Uma Shankar has to answer, or maybe Chandrasekhar might talk about it, because these are the people who generally deal with the registration, show interest. As far as I know, I'm talking about a mental health clinic which doesn't come under the purview of Mental Health Act. That's why I could confidently talk about it.
Thank you, madam, for the lucid presentation. On this occasion, I would like to appeal to all the postgraduates that there is a huge scope of starting a mental health clinic for children or a child rehab center, child guidance center. In our city of Hyderabad, we have, I would say, he calls himself a neurologist, a child development person, and he has around 10 to 12 centers run by, as Dr. Rishi was saying, not so qualified people. So all of us, all of the youngsters can start their own child development center. I think Ravi has started one. Ravi is doing lots of work in child psychiatry, and you can take guidance from madam or Ravi or Rishi and start your own centers. It doesn't cost much. You can just liaison with a psychologist and start your own child guidance center. Thank you.
Thank you. At this stage, I would like to thank Dr. Minaj for giving his, residence for starting our center. Thank you.
With your permission, can I ask you an odd question? You are very sensitive and
No,
socially
I'm not
sensitive.
sensitive, sir.
And yeah, I'm sure you can take up. I'm asking a question which most of the people here would think it's out of the way. But sitting here, when I was going through your excellent presentation, you are known for your child psychiatric services, etc. One thing, once in one psychology conference when I was talking, one psychologist said Why is it psychiatrists always take the example of abnormal people? Why don't you take the examples of normal people and their problems? Here, I thought of an odd way. There are people who are not according to the parental expectations, like studies, etc. There are people like dropouts at seventh class, like one H.V. Kamath. He was a dropper, and he started raising his own, and he has become a billionaire. And there are people, women also, who are not in the usual studies, usual behavior, but they have become CEOs of companies because they have not followed. Parents are not happy with them initially. Parents are for socially accepted and money-making courses. One of the, I will not go deep into that. My feeling is the, what do you call it? The usual psychiatry has missed some of these things. You see, you might once in a month take up a case where parents are complaining about a child and get his IQ assessment done or your psychometry. You might turn out to be a creative person. IIT Ramaya was interviewed recently. He is known to have produced IIT in his. And he was asked by somebody, sir, is the IIT the end of the courses? He said, no, madam. Now IIT is not the thing. It is the creativity that's going to rule the country. So, some of these children might be creative. So, once in a month or something, you might take up these children who are creative, and I try to assess them. For example, I call it mainstream psychiatry. How is that it has neglected? Not that I know much about the thing, but for example, 2,500 years back, we are told the first cognitive therapist was Buddha. How many of us know about Buddha and his principles? We don't know. And how many he has treated people? And Vivekananda said, in the whole of human history, if there is one person who has done exceptionally good, it is Buddha. And in my MD psychiatry, they said we will expose you to psychiatry. One class was taken, next time they did not. That's okay. But what all I am saying is, can we look into these deficits which we might cover? I don't know.
I fully agree with you, sir.
I ask the pardon of all the public here. I am asking an odd question. I am sorry. I am an old man. I think I have the right to ask
No,
such
as
questions.
an experienced man who have seen and worked with so many patients, you have the right, sir. Basically, what I would say is, as the definition goes, psychiatry is the field of medicine which deals with the abnormal psychology of the individuals, abnormal individuals. Having said that, I'm not saying that we are going to ignore the people so-called normals. Coming to child psychiatry, as you rightly pointed out, many of the parents bring saying that the child is not good. And many occasions I found the children are genius. They're not able to, cope up with the normal children. So such cases, I did examine them. It's most often I examine them, get their intellectual assessment done, their strengths and weaknesses we identify, and most often we counsel the parents. There are a number of children who thanked us, saying that my parents have brought, adolescents also. So they are normal, but they are abnormal to the parents because the parents have abnormal expectations. And they want the children to be showpieces in their house. So that's the reason, and most of the people, the idea, like recently I've seen most of the adolescents, the parents say that you need to do IIT, you need to go to America, you need to make money. You know, that's the ultimate thing. And also, like children say, like, no, one child is borderline intelligent. And the parents say that, no, you have to go for IIT. The boy says that he cannot. You know, the parents. And there is another family where the child is mentally borderline intelligence. He cannot study. And the father made him pass the exam 10th and intermediate. He tried to engineering, he committed suicide. His sister was brought to me again, saying that she's the only survivor and she has to do, you know, studies. The girl is, you know, mild mental retardation. And then I have to tell them, because I could identify, I said, see, listen, they need to have capacity, they cannot. So this is where we need to identify the normal people and know the creativity and encourage. Recently, one child with autism came with, you know, so much of ability, I mean, like music. He's so good. And I told them to put him into the music therapy, and then maybe I'm going to introduce to the music therapist so that he will develop. So there are a number of children, as you pointed out, they have what you call special abilities. Need not be IQ. IQ might be good, but the thing is they do have special abilities. So it's not that in child psychiatry we deal with only abnormal children, but we do look into the, you know, the skills of the children and their expectation of the parents, and accordingly we guide them. There are a lot of times the parents are very unhappy with us, but we put it in a very subtle way and then give them time to think it over and come back to us.
Sir, here the problem is the most of the parents, they want to enter their children to the financially secured courses. They want to see their children to settle the financially. So that's why they are sending most of the parents to the financially secured courses, routine courses.
But some of these children are making billions who are not following the parents.
Sir, that is what you call social and emotional intelligence. It's not the general intelligence.
But why
So
don't
we
we
need
look
to-
at that as...
Yeah, sure, sir.
For
Sure, sir.
example, iPhone was
Yeah.
made by whom? He started in a garage. He was working in a company, working in a garage. He has become a billionaire.
True, sir.
iPhone.
Yeah,
So there are people with these
Yeah.
abilities. Why don't we look at it
sure, sir.
once in a way, once
Yeah.
in a month or something? That's all.
Sure, sir. Thank you, sir.
Thank you, ma'am. With this, we will conclude the session.
Really shown through. I now request the chairpersons to present a memento and bouquet to the speaker. I request the speaker to present the memento to the chairpersons. Dr. Uma Shankar, sir. Sorry. Yes, sir. To Dr. Srilakshmi, ma'am. Yes. Sorry. Next. Yeah. Yes. Yeah. Thank you to the speaker and the chairpersons.